Ray. Good afternoon. Thank you for being at the Difficult Airway Management presentation today. My name is David Carter. I'm a nationally registered paramedic and a critical care EMTP as well. Today's presentation is going to be on difficult airways. I know we've all had them. We've seen them out in the field. With a show of hands, how many of you all have had a difficult airway problem or know what it is? Thank you. Difficult airway management. A difficult airway exists when pre-intubation examination has identified the need for a difficult airway situation or surgical airway management. What this can entail is when the paramedics out in the field or the EMTs out in the field, they need to put a BBM, use a BBM on a patient, drop an OPA or an airway adjunct, and you cannot ventilate the patient. This is a difficult airway. There are several different acronyms and synonyms that we use in our field. We're going to look at a few of them here. We're going to take MOANS, for example. M-O-A-N-S. M stands for mask. Are you getting a good seal with that mask? Is there puke on the patient's face? Is there excessive hair on the patient's face? What is causing you to not be able to get a good seal when using a bag valve mask? O for obesity. There's several different reasons out there. Take, for example, a woman that's in her third trimester. She is going to have more of an obese face, facial features. You get that 800-pound patient that's on a code arrest, that the body just sags everywhere. You're not going to be able to get a very good seal. A, age. Age plays an important factor in a lot of things. In this instance, we look at industry-wide as a person that is 55 years of age or greater is possibly going to have a difficult airway problem due to the fact that they have deteriorating muscle tissue, loss of elasticity in the face, many different situations. N for teeth. Again, with that elderly person, an 87-year-old grandma who has no teeth but false teeth, you take them out, the facial features collapse. You will not get a good seal with bag valve mask. S for stiff lungs. And what that entails is when you're trying to bag that patient, say you got that OPA and you're trying to bag and you get that compromise, you're just not being able to squeeze the bag. Maybe they have upper respiratory problems, maybe they have asthma, maybe they have something else going on in their life that has caused a problem. That's what they call stiff lungs. Another approach to the difficult airway is lemon. Think of it as when you're buying a used car. Everyone's done it. You walk out there on the field, you look for something out there. Is this a lemon or not? You're going to look at the exterior. You're going to look at the patient's face. Is there a traumatic injury? Is part of the face missing? Is there air bubbles coming out? That is for your L, for look at it externally. E, evaluate. The 3-3-2 method. And what that's going to entail is, I've got a mannequin here to show you, is you're going to take the patient's hand, you're going to take 3 fingers of the patient, you're going to try to put it into the patient's airway. If it goes in successfully, you're on the right track. If it doesn't, you run the risk of a difficult airway. The next 3 fingers of her finger, you're going to go from the chin, lay it back, it's going to hit the back part of the anterior portion of the neck. If it fits in there perfect, great. If it's only 2, you're going to run the risk of a difficult airway. Then you're going to take 2 fingers, and you're going to go from the back anterior portion of the neck down to the Adam's apple. If it fits, if you have the 3-3-2, you will not run the risk of a difficult airway. But any of those that come out, you run that risk of a difficult airway. M, malapative. And what I'm going to show you right here is this. We have four different views to look at. Your grade 1 is your perfect airway. That is what every paramedic loves to see. Grade 2, you're starting to lose your vocal cords, but you can still see the epiglottis up on the top. 3, you have lost your vocal cords, you can see the epiglottis, and you can see the bottom portion where you might be able to get a tube in. 4, this is a total airway compromise. You will not get that airway. O, obstruction. What's obstructing this airway? Did they swallow candy? Were they hit in the throat? Something is obstructing the airway. You're not moving air. No sounds, no nothing. N for neck mobility. Why can't we adjust that neck? We try to adjust the neck to hyperextend it, or are they wearing a C-collar because they were in trauma? These are some of the things you have to look for with lemon. The next approach we're going to look at is rods. You're going to look at the R, restricted mouth opening. Do they have TMJ? What is causing them from being able to open the mouth? Is their teeth clenched? O, obstruction of the larynx. So the larynx is right here. So what is blocking that larynx? There's something there you need to try to evaluate. Were they chewing on some meat? Did it get lodged? Did they get hit? D, disruption or distortion. What is distorting that airway? What is causing that problem? S for stiff lungs. Again, can you bag them? Do they run the risk of upper respiratory, lower respiratory? Do they have pneumonia? What is some of the problems causing the stiff lung portion? Another one is for your surgical cricothotomy. Short. S for surgical. Do they have an incision? Do they have problems with this? What is causing, a problem of possibly having to do a cric? H, a hematoma. Do they have a blood pocket? Do they have a bruise? Do they have a giant abscess in that area? You do not want to cut that. O, the obese patient again. Are they pregnant? Are they just overly weight? You need to look at that because their neck is going to be humongous. R for radiation. Did they have some type of cancer? Did they get radiation therapy? What has caused the deterioration of the throat and the neck area? T for your tumor. Do they have an abscess? Do they have cancer? And you'll see it, once you're out there, because you do not want to cut into these areas because those are compromising areas. These are just some of the different ways to approach a difficult airway. So in summary, what we need to look at is, was this a difficult airway problem? Did we define it? Did we use drugs to help manipulate the airway? Were we able to oxygenate the patient? Was a bag valve mask used, and was it used successfully? Were we able to avoid an emergency cricothotomy in this patient? These are just some of the things that with this presentation is showing of some of the different things that we try to assess. Some people in the industry think that the cricothotomy is the cornerstone in airway management. It can be. One of the quotes out of our book that a friend of mine did, John Sackles, his quote is, "The difficult airway is something one anticipates. The failed airway is something one experiences." Thank you for attending this presentation today. Have a good afternoon.